So I think it really depends on whether it's a soft posterior polar or whether it's a dense one, because the risks are different and the way I handle them would be different. So if we have a soft posterior polar cataract, we could do it with hydrodelamination, which means we push the fluid within the nucleus but not just under the capsule, or we could do it without pushing any fluid into the eye. And with the femtosecond laser, it's really advantageous because we can actually determine, first of all, the capsule size, so that in the event there's a capsule rupture, we can use this well-centered capsulotomy that is sized smaller than the optic to actually optic capture to support the lens, even if there's no posterior capsule there. In addition, with the fragmentation of the nucleus, if we do hydrodelaminate, basically we can actually join, say if you have done sextants, so you have 6 pieces there, you can actually do it in the plane where you basically join the edges where the radial segments end, and basically you have now 6 pieces that are really freed already by the fluid. Okay, so you can then, without rotating the outer shell of this epi nucleus, you can just aspirate and bring these pieces out of the capsular bag and phaco them and remove them very safely and not break the posterior capsule until the epi nucleus is removed. We can do it also with viscodissection. So what I would do with the soft cataract then is just put some viscoelastic in the subincisional areas. So the main incision and the side port incision, I would put just viscoelastic under the capsule, inject it until it reaches about the equator, and that's where I would stop. And the purpose of this is basically to help to free the epi nucleus. So when we do the femto fragmentation, basically we have a 600 micron offset, which is the minimum offset. And that should actually, visually, we should see that it is above where the polar opacity is, so that there is no breakthrough of gas into the polar opacity that may communicate with the posterior segment and cause a rip of the posterior capsule. So once we are sure this is safe, we do the viscodissection to release the epi nucleus when the time comes when the nucleus has been removed. Otherwise, it can be very sticky and can be difficult to remove the epi nucleus, and it can be even more difficult to remove the epi nucleus than the nucleus of the cataract. So after putting the viscodissection, we then carry on with the surgery as per standard cataract without putting any fluid in. And in these cases, then I would do a little sculpting in the center. And once we have that little trough there, I then use the phaco needle in the trough to provide the counter force. When I put my chopper across into the capsular bag just under the anterior capsule, and with this counter force, I then bring my chopper against the phaco needle to actually free out the fragments here. So once I've done that, this is simple because it's away from the incisions. The challenge comes when we're trying to remove the epinucleus, the nucleus on the side where the incision is. So that's why I've got viscoelastic here that helps me to release this part of the nucleus. So after I've removed the quadrant here, across where it's completely cut already, I can remove the next quadrant here by using my chopper to merely just pick it out and cause it to roll forward and then tumble forwards and remove it with phacoemulsification. And when we have this heminucleus here left, where I cannot really use this instrument that's in the side port to actually remove and dig this forward, I can't do that easily. So with that viscoelastic there, it actually has already loosened the nucleus up to the equator. So what I then do is just with my phaco tip, I impale this heminucleus, and when I try to bring it forward, you find that this is very loose already because of the viscoelastic, and I can easily remove this into the capsular bag, phaco it without having to rotate and break that communication with that polar opacity. So in that way, I can actually remove it without breaking the posterior capsule. And actually, with this kind of technique, it's really dropped my PCR or posterior capsule rupture rate down to something like 3%.
Wow.
When dealing with a hard posterior polar cataract, it would be similar to what I just described to you with no fluid and just doing that viscodissection over the subincisional areas, and then it's exactly the same technique with sculpting a little trough in the center, trapping across with the counterforce being provided by the phaco needle on the side away from the incisions, and the side near the incision, the viscoelastic is already loosened, everything here, and this comes off as a quadrant or a heminucleus, which I chop again and then remove bit by bit and completely remove without breaking the adhesion to the posterior polar opacity.